Okay, so up to this point, we've talked about evaluating the environment that mom and baby are living in, things that we can teach mom to have a healthier and safer pregnancy, lab values to evaluate the pregnancy. Now, the rest of these little talks today are going to be about evaluating the healthy pregnancy through the eyes of the fetus. What is the fetus trying to tell us? This is broken down. This can be some hard content, so I've broken it into smaller little pieces so you can get some of the information, take a little brain break, and then jump back into it. So let's get started. In the beginning, a little boy goes to his dad and asks, "Daddy, how was I born?" The father answers, "Well, son, I guess you will need to find out someday anyway. Your mom and I got together in a chat room on Yahoo. Then we set up a date via email with your mom, and we met in a cyber cafe. We sneaked into a secluded room where your mother agreed to download from my hard drive. As soon as I was ready to upload, we discovered that neither one of us had used a firewall, and since it was too late to hit the delete button, 9 months later, a little pop-up appeared that said, 'You've got mail.'" Now, you can't expect an OB nurse and an OB instructor to get something like this in an email and not use it in a lecture somehow. So let's get started. We're going to talk about electronic fetal monitoring, and that is evaluating what the baby is telling us about his intrauterine environment. And we're going to end these lectures with talking about antenatal testing and evaluating how that baby is doing. Up to this point, we've talked about how mom is doing, so now we're going to talk about how the baby's doing. So we start fetal monitoring after about 28 weeks, because before that, our babies are too small to stay on the monitor, and their little bodies are so immature that we can't really evaluate and interpret anything meaningful from any data that we get. It's used throughout the pregnancy from about 28 weeks and beyond to determine fetal health at any point during that pregnancy. So a high-risk pregnancy may come in once or twice a week to get fetal monitoring so we can evaluate how this baby is doing. Or some of our moms don't get any of this fetal monitoring. If everything is healthy and well and going along like it's supposed to, she may not actually get on the monitor until she comes into the hospital in labor. Anyone that presents to L&D or L&D triage with any complaint is going to get fetal monitoring before she leaves and goes home. So she can come in because she has a cough. We could treat the cough, but before she leaves, we're going to put her on the monitor to evaluate and ensure that mom and baby are healthy when they leave the hospital. So hopefully you have heard about evidence-based practice prior to today. What is evidence-based practice? It's the use of research to guide what we do in our practice. An evidence-based practice for fetal monitoring comes from A1, which is the Association of Women's Health, OB, and Neonatal Nurses. That's my professional nursing organization. They set the national standard for fetal monitoring. They set the national standard for how we respond to what we see on the monitor. And so all of the rest of this content is from A1 and from their fetal monitoring program. Note in your lecture handout, your guided notes, other sources of evidence-based practice and what other sources are used to establish standards in your hospital setting. A1's position statement on fetal monitoring says, fetal heart monitoring requires advanced assessment and clinical judgment skills regardless of the setting in which it's used. Meaning the OR nurse who is caring for a pregnant patient needs to read that monitor like the OB nurse. The ER nurse or the ICU nurse that has a patient on the monitor has to be able to read that monitor like the OB nurse. In most cases, they can't do that. So OB nurses go to the ER or go to the ICU to help read those monitors and ensure mom and baby stay safe. Initiation of monitoring and ongoing clinical evaluation should only be performed by healthcare professionals who have education and skills validation in fetal heart monitoring and in the care of laboring women. They further state that healthcare professionals with this expertise in fetal monitoring are RNs, certified midwives, other advanced practice nurses such as a nurse practitioner, clinical nurse specialist, physicians, and PAs. A1 believes that fetal heart monitoring should not be delegated to personnel who do not possess this level of licensure, education, and skills validation. Please look at who is not on this list above. LVNs are not on this list, and CNAs are not on this list. Now, they may work in L&D, but we cannot delegate fetal monitoring to them because A1 says they don't have the skills to be able to effectively and safely evaluate the fetal heart monitor. It's not to say that they don't know a whole lot, especially if they've been working there for a whole long time. That is not a skill an RN is allowed to delegate. How frequently are we monitoring this baby? A1 says that in the absence of risk factors, meaning this is a normal, healthy pregnancy with no complications, she's not being induced, she's not having any medications to stimulate her labor, then we evaluate this baby every 30 minutes during the first phase, the active phase of first stage, and every 15 minutes during the active pushing stage. When we do have risk factors such as pregnancy-induced hypertension or preeclampsia, diabetes, cardiac disease, she's getting medications to induce or enhance her labor, we are evaluating this fetus and this monitor every 15 minutes during active phase. And keep in mind, active phase can be 19 hours. And then every 5 minutes during the pushing stage and second stage. And that can be a couple hours. This is implying that we are documenting every time we're evaluating. So we're evaluating every 30 or 15 minutes or 15 and 5 minutes. We're supposed to be documenting that frequently about what we're seeing and what we're doing about what we're seeing. Let's make a couple assumptions about what we're doing. Anytime you're looking at the fetal monitor, you cannot look at the fetal heart rate in isolation from what the contractions are. Some of our strips that we're going to look at, in fact, a lot of our strips that we're going to look at today are just the fetal heart part of that. And that's out of convenience to make it big enough for you to be able to see it. But in real life, you cannot talk about the fetal heart rate in the absence of what the contractions are doing and how this baby's heart rate is responding to those contractions. Because after all, what we all want is this healthy, happy, full-term infant. Let's talk about the equipment a little bit. This one over here on the lower left-hand side is our Toco transducer. That is a monitor, this little button right here. When mom has a contraction, her uterine wall moves to the outside, so toward mom's abdomen, exterior abdomen. So it puts pressure up against this little button. And that's transcribed through the, miracle of computers and all that kind of stuff into a visual representation on the fetal heart rate paper. This is the fetal heart rate. So we put some gel on here, either ultrasound gel, maybe hand lotion. That's what we use at one of the hospitals I do clinicals at. So that there is a conductive medium between this and mom. And this is how we listen to the baby's heart rate. These are both external monitors. This is like a giant stethoscope. This is just seeing pressure. So if mom turns over and kind of lays on this, we can see a big spike on the paper. That doesn't mean it's a contraction. It means there's pressure up against this. So we have to evaluate what's going on while we're looking at what's on the monitor. So this is on mom. We put this on the fundus, the top of the uterus, not the top of the abdomen or the top of the stomach where it starts to take a dive in underneath her breast. We're going to find out where the top of that uterus is, and we're going to put this. So when mom has a contraction, the uterus kind of moves up and pushes up against this and creates a wave down here on the paper. And then our fetal heart rate monitor. This is actually on the outside, although this picture doesn't make it look like that. We're going to listen through the baby's back. That's where we can hear it the best. And this is just a giant stethoscope listening to sounds in there. Well, that means that we can also hear blood flow through the cord, blood flow through the placenta right here. Means we can also hear bowel sounds. So we need to make sure that what we're listening to is actually the baby. One of the best ways that we can, when you do this for a long time, you can typically tell the difference between the fetal heart rate and when it's going through the placenta or the cord. But another way to make sure is reach up and take mom's pulse while you're listening. If what you're hearing is exactly what you're feeling, the odds are that you're picking up blood flow through the cord or the placenta. So this is an internal monitor. This is the internal fetal scalp electrode. This little spiral electrode right here actually attaches to baby's presenting part. Typically the head, but it might be baby's buttocks if this is a breech baby. This is picking up baby's electrical activity. So just like when you go to your doctor and he hears something abnormal with his stethoscope, he's going to send you for a different kind of evaluation, typically an EKG, so that we can see the electrical activity of your heart. That's what this is, so that we can see the baby's heart. This attaches to the cable that comes out of the fetal monitoring machine, and it helps us evaluate baby's heart rate. And this over here is an intrauterine pressure catheter, so an IUPC. This little thing right here is inserted through the cervix. This is attached to the presenting part of the baby as it goes through, after it goes through the cervix. This actually goes through the cervix and then lines up and lays in between the baby and the uterine wall. And every time there's a contraction, pressure is exerted on this little probe right here, and through our magical technology with the computer, it gives us a visual representation of that contraction. Now with an internal pressure catheter in, we can tell exactly how strong those contractions are. When they don't have this, if they have the external monitor on, all we can say about contractions with an external monitor is how strong they palpate, how long they last, and how frequent they are. With this, we can tell exactly how strong these are. And so with an external monitor, we talk about how those contractions palpate. So reach up and touch your nose. You can mush your nose quite a bit before you get to something firm, your nasal septum, okay? If you're palpating and feeling mom's uterus, her fundus, how much dent can you put in that uterus during a contraction? If you can put quite a bit of dent in, like your nose, then that's called a mild contraction. Now reach down and feel your chin. There's just a tiny bit of mush, but then you get to that firm chin bone. So if while you're feeling mom's fundus, her uterus, during these contractions, if you can barely dent that at all, then we call that a moderate contraction. And then reach up and feel your forehead. When you push on that uterus, it feels like your forehead. It's not dentable. Then that is considered a strong contraction. So with an external monitor, all you can say is that they're mild, moderate, or strong. With our internal monitor in, you can talk about exactly how strong those contractions are. Why do we all need to hear and speak the same language? Because in an emergency, I need to very quickly be able to notify my provider that I have an emergency and they need to come and evaluate this baby. We all need to be working from the same premise. If I have to call and say, well, I have a baby whose heart rate was 110 and now it drops down and sometimes it's 105 and sometimes it's 107, and I don't have any variability, it's really flat and smooth. And then sometimes after the contractions, the heart rate goes down and it takes a while to come. That's a lot of wasted time on trying to get my provider to understand I've got an emergency. And I certainly can't call him and go, I need you, come here now. Just like when you're in ICU, you can't call and say, well, I had this person who had this little thing that it went to the negative side and they had a whole bunch. You're describing a run of PVCs. You need to be able to call your provider and say, they're having a run of PVCs. I need an order or I need you to come see them without having to describe every single little thing that you're seeing on your monitor. They need to know either baby's okay or not. They need to come right now or they're good not to come for a little bit. And so we all need to say the same thing because we have standards about what we do, about what we see. And we all need to be able to identify when we need to do action and when we don't. So where do we start? We determine where the fetal lie is based on Leopold's maneuver. Remember, we talked about we're going to find out where his small parts are, his hands and his feet, where his back is. We're going to determine if he's in a head up or head down position. So we know where to listen for the baby's heartbeat. It's best heard over the fetal back. It should be in the lower abdomen. If it's above the umbilicus, then we have to consider that this baby might be a breech baby. And if she's in active labor, we probably need to do something about that before too long. A lot of times when we can't tell which way baby's laying, sometimes there's just so much fluff that you really can't feel what you're trying to feel. Always ask mom, where do you think baby's hands and feet are? They know where they're getting kicked and punched. They know where those baby's hands are and feet. And so they also know where the baby's back is. They're as accurate as we are with Leopold's. Next, we're going to apply a fetoscope or a Doppler, and we're going to find baby's heartbeat. We're going to determine that we're not listening to mom and we're not recording mom's heart rate. We're going to wipe off all that extra goo that we had on that transducer before we put the straps on. Now here's some more equipment that we use on L&D. This is a Doppler. This is exactly like the Doppler you use on Med-Surg. This is the one that we should be using, and this is the one that we typically use in our outpatient prenatal visits. Everybody in the room can hear exactly what's going on with this. This is a great way to reassure everybody in the room that this baby is doing well. This, on the other hand, this is also a Doppler of sorts, but the only person that can hear what's going on is the person wearing the stethoscope part of this. So if you find baby and then you move this and let mom or the visitors in the room listen, the odds are that this could move and they don't hear anything. That is not reassuring to a patient who's concerned about their baby. Here, listen, and all of a sudden there's nothing. That just reinforces that there's a problem. So this is not ideal. This is ideal. Now this is an old-fashioned fetoscope. This goes on the baby or on the mom's tummy. The listener puts their forehead on this. They put this in their ear and they can hear the baby's heart rate. We did this forever and ever. Not we, I'm not that old, but they used this forever before we got these Dopplers. And this was very effective at being able to hear baby's heart rate. A lot of times, the only place you're going to see this is in medical archives or like a museum, or if the hospital has, a display of old-fashioned equipment, this might be in there. We don't tend to see these on units too much anymore. But this is perfect. It requires nothing besides mom's tummy, the listener's forehead, and the listener's ears. These require batteries. What if you run out of batteries? You can't listen to baby's heart rate? We're going to evaluate the contractions. We're going to palpate for those contractions. Then we're going to place our toco, usually on the fundus. When we talk about contractions, we're always going to talk about the frequency. And the frequency is from the beginning of one contraction to the beginning of the next. We're going to talk about the duration of a contraction from the beginning to the end of a contraction. And we're going to talk about the intensity. And that's either the mild, moderate, or based on what you're palpating, or if you've got your internal monitors in, you're actually going to use the numbers. And I'm going to show you that on a graph paper here in a minute. Before you leave the room after you connect her, make sure that you're capturing the contractions. Tell mom to let you know when she has another contraction so we make sure that it's recording. If we're going to have her on the monitor, we need to make sure we're capturing what's actually happening in that room. What is normal for contractions, and how do we time our contractions? We talk about the frequency, and that's the number of contractions present in a 10-minute window, averaged over about 30 minutes. So we're going to look, and we're actually going to count from the beginning of one to the beginning of the next, to the beginning of the next, and it's typically going to be a range. Most people don't have an exact, it's actually exactly every three minutes. So if it's every 3 to 4 minutes, 3 to 5 minutes, we're going to put that range down. We're going to look at this latest 10-minute window, look back and see if that's what they've been doing over, like, since the last time we assessed her about 30 minutes ago, and is it the same or has there been a change? And what we say is normal are less than 5 contractions, 5 or less contractions in a 10-minute period. A frequency that close means that there's enough time for our babies to catch their breath in between each contraction, and they tend to do well. If we have more than 5 contractions in 10 minutes, we call that tachysystole, or you might hear the term hyperstimulation. That's too many contractions, and even our healthy babies are going to have trouble with contractions that frequently. And part of the reason for that is because when we have contractions that frequently, when a contraction is at least a moderately strong contraction, that means blood flow through the placental bed ceases during that contraction. There's so much pressure in that uterus, there's no blood flow. And so healthy babies can hold their breath every few minutes for 60 seconds or so. But we start telling them to hold their breath more frequently than every 2 minutes. Even healthy babies are going to have a problem with oxygenation. We are always going to document our fetal heart rate reaction to this hyperstim or this tachysystole contraction pattern. And more importantly, we're going to talk about what we did and how that baby responded to our interventions. Now, this is a picture of fetal monitor graph paper. This upper section is the fetal heart rate. The lower section is contraction patterns. If you notice, we have 30, 40, 50, 60, 70, 80, 90. That's the fetal heart rate. So this is 60 beats per minute, 90 beats a minute, 120 beats a minute, 150, 180. This black section right through here is where this monitor's alarms are set. So if you notice, here's 90, there's 100. So this alarm, the lower level alarm is set at 100, the upper level alarm is at 180. And we said that the normal range is 110 to 160. Well, sometimes when our babies are sleeping, they might dip just a little bit below that 110 line. We don't want the alarm going off every single time that happens. And when our babies are moving around and they're happy in there and they get startled and whatever, their heart rate can go above that 160. And we don't want the alarms going off every single time. If it's above that 160 for any length of time, a minute or more, less than the 110 for a length of time, we need to investigate and evaluate. We can't say, close enough to normal. It's not normal, therefore we need to intervene and find out what's going on. Now, if you notice from this tick mark, this dark line here to this tick mark and this bold line over here, from tick line to tick line or dark line to dark line, and on regular graph paper, these are darker, these big lines are darker than they appear on this graph. So this is 1 minute from this line to this line. If you notice how many blocks are in between there, 1, 2, 3, 4, 5, 6. So there are 60 seconds. Each of these blocks are 10 seconds long. So that's one way of helping to time something, because our babies or our contractions never start exactly on this line. So if you're counting from the middle, you can count how many blocks we've got, 1, 2, 3, 4, 5, all the way, say, to 14 blocks. 14 blocks is 140 seconds or 2.5 minutes. And that's an easier way than we don't have to get out our calipers and measure these things like you do in critical care. So now this bottom piece is our contraction pattern piece, okay? So when we have these contractions, if they go all the way up here to 100 and back down, and then they go back up to 100 and they go back down, if we're talking about an external monitor, all we can say is that these are mild, moderate, or strong, because it doesn't matter what they look like on the graph paper when we have an external monitor. It depends on mom's position. It depends on how much fluff mom has between that uterus and that toco. It depends on how tight we've got that belt pulled. So all we can talk about is what we actually palpate. But if we have our internal pressure monitor in, then if these contractions go to this every time, when we're talking about the intensity of the contraction, we can say the intensity is 80 millimeters of mercury. This is measured just like your blood pressure is. So if it's 80, 75, 80, 75, then we can say the intensity of her contractions are between 75 and 80 millimeters of mercury. And we can be that specific, but only when we have an internal monitor in. So we want to look at the baby's heart rate. And the best thing I can tell you about evaluating and learning fetal monitoring is please go one slide at a time with me. Understand what I'm saying about this slide, and then let's move on. And as we build these pieces, this will all start to come together and make sense. So we're going to talk about the baby's heart rate in relationship to the contraction. So if what we're seeing on the monitor only happens with a contraction, that's called a periodic fetal heart rate pattern. If it happens with or without the contractions, it doesn't require the contraction, then we're going to call that a non-periodic change. That's important when we're evaluating the fetal monitor. Is this pattern only when she's having contractions, or is this happening irregardless of the contractions? So what we're going to learn when we really get into the meat of this is you are going to learn how to evaluate and interpret your fetal monitor strip from a systematic approach. Always start with a baseline fetal heart rate. Where does this hang out most of the time? What is the baseline fetal heart rate variability? Before we're done with this section, you will know exactly what that means and be able to identify that. The presence or absence of accelerations. Accelerations, just like if you accelerate the car, that's an increase. So it's an increase in the baby's heart rate. Do we have periodic or episodic decelerations? If the car decelerates, it slows down. So a deceleration is a decrease in the baby's heart rate. Is that happening only with contractions, or is that happening regardless of the contractions? It happens even in the absence of contractions. Then we're going to talk about changes or trends in the fetal heart rate pattern over time. We're going to talk about how to determine the frequency, duration, and intensity of your uterine contractions and the resting time. So now it's time to take a brain break. Think about that for just a few minutes. Get up, stretch, take some deep breaths, get something to drink, go to the bathroom, and then come on back and let's finish this up.